So, first of all, please accept my condolences on what you have done today. Honestly, we didn't know. I came to know the 11 or 12 o'clock. You must be aware some group, parts of group in the class. You must be aware here and there. So because we can know knowledge of this, we will part of life. We will move on. Okay. The lecture of today is the one which is important in the sense that these are the mostly widely used among all the drugs in the world, throughout the world. Because among all the symptoms for which patients visit doctor, one of the most common cause is pain. Because of the pain and fever, they visit doctor. The drugs which we are going to discuss are mainly for the pain, fever, and anti-inflammatory drugs. So I am sure in this classroom, all of you have used one of these drugs in your lifetime or your family members. Almost everybody has used these drugs. You must be having fever, painful conditions. Today, we will first define the term analgesic, anti-inflammatory, and antipyretic. And then we will differentiate between narcotic and non-narcotic analgesics. And then we will classify the non-narcotic analgesics based on their selectivity for COX, cyclooxygenase enzyme. And then we will discuss the mechanism of action, clinical uses, and the adverse effects of analgesics. So first of all, definitions as per the learning objectives. Anti-inflammatory, as the name indicates, any drug which is used to reduce or prevent inflammation is anti-inflammatory, simply. And you have a lot of lectures on inflammation from pathology. So that will be contextual. And then we have another term, analgesics. Analgesic is a drug which is used to prevent or reduce pain. And this is a big thing. Analgesic is a big thing. I will in the subsequent 2-3 slides, I will tell you what we are going to cover today, what we are going to cover in the subsequent blocks. So painkillers, commonly used painkillers, the term used painkiller, analgesic. And then the third is antipyretic in the context of today's lecture. Pyresis means fever, thermia. Any drug which is there to reduce the temperature, reduce the fever, is antipyretic. Okay. Let's move. Now, pain biology is a huge subject. Pain management, pain biology, how the pain sensations rise, how they're traded in the nervous system, and how the pain is perceived at the higher level. Pain has various components. Pain has a stimulus, pain has injury, thermal, chemical, or whatever injury. And your reaction towards pain is another component. For example, let me give you an example. These two gentlemen have similar extent of injury, but their response would be different. That means it is not the pain per se, injury per se, which is causing the pain, but how do you react towards that sensation is also a part of it. That is another topic, detailed topic we will cover in neuroscience. For example, here, if you look at this, whenever Abraham has mentioned in his lecture on inflammation, whenever there is injury, any traumatic, particular, there are various chemical mediators are released, facilitate and decrease the threshold of the sensitization of the painful nerve endings. They are mainly from the fiber C, delta fiber, and then the first nucleus is the dorsal root ganglia, and then the sensation travel from the spinal cord to the higher center, and then pain is perceived. There is something happening, something injurious, toxic, noxious is happening in the body. You have to react to that. Now, prostaglandins, serotonin, bradykinin, potassium, and H ions are the culprit mediators which sensitize the peripheral nerve endings whenever there is injury. The pain impulse travels, dorsal root ganglion into the spinal cord and into the higher center. Now, based on this whole cycle of pain origin and perception, you can block the pain at the level of periphery by decreasing those chemical mediators which are sensitizing the nerve endings, which we are going to discuss. It means the drug which decrease the synthesis of those chemical mediators which sensitize the nerve endings to carry them to the higher levels. It is the most peripheral mechanism of pain reduction. Is that clear? Down the line, you can also inhibit the pain sensation by inhibiting the transmission of pain sensation from the periphery towards the spinal cord. When we call those drugs as analgesics, no, those are anesthetics, local anesthetics, because they do not carry only the analgesic means decreasing the pain sensation. Whereas these anesthetics, local anesthetics, they decrease all types of pain, including pain. So they, strictly speaking, they do not come under the class of analgesics. They come under the class of anesthetics. We will discuss later in neuroscience. So here, most peripheral side, decrease the synthesis of chemical mediators, decrease the transmission of impulse towards the spinal cord, and then you can also decrease the pain sensation, the perception at the higher center and the midbrain that will also be coming in the neurosensory drug. Those drugs are very, very important drugs known as opiates. You might have a morphine, heroin, fentanyl, those are the drugs. Those are also known as narcotic analgesics. Those are analgesics because they specifically use pain sensation. These also use specifically pain sensation. Since these are not depend, I mean, they are do not cause dependence, they do not cause sedation. They are known as non-narcotic. There is the drugs which decrease pain sensation at the higher centers and cause dependence. The CNS, they are known as narcotic. So we will discuss the neurosciences, narcotic analgesic, okay. We will discuss the other areas of neurosciences. Today we are discussing. They are also known as non-steroidal anti-inflammatory drugs. Why we call non-steroidal? Because to differentiate them from the glucocorticoids like prednisone, dexamethasone, which are steroids. Steroids but anti-inflammatory. Here they are non-steroids but anti-inflammatory. Okay. Let's move. Potential sites of action. What happened? Class? Potential sites of action of inhibition of pain. Just for your concepts, no need to memorize. I think mentioned here. I already explained. Anything else? You want to further explanation? Yes.
The last two are the narcotic.
Yes. We'll discuss neurosciences, we'll discuss anesthetics and neurosciences, but here the first thing at the peripheral sites, we'll discuss here. Inflammation, Abrar has already covered. So various mediators of inflammation synthesized and released by leukocytes, they cause the synthesis of prostaglandin E2 and various other prostaglandins. They cause vasodilatation. As a result of vasodilatation at the capillary level, there is redness and warmth, which gives. That's the problem. Please. Okay, I can use this one. Okay. I have to be standing here. I can't move against my habit. I always move around. So prostaglandins, they cause vasodilatation. As a result of vasodilatation at the capillary vascular level, there is a redness and warmth, which gives the characteristic feature of inflammation. Whenever there is a redness and warmth, high temperature and redness is redness. What is the feature of what are the features of inflammation? Redness, warmth, loss of function is fifth and fourth. So increased fluid transfusion across leaky capillary plates may cause exudation, may cause edema and swelling. And then prostaglandins, as I mentioned, they also cause pain. They do not cause directly pain, but they stimulate the nerve endings that will travel towards higher center, will cause pain sensation. Okay. Antipyretic effect, I mentioned briefly about inflammation. In the hypothalamus, which is the major, you will learn in neurosciences, which is a major center for heat regulation in the body. Okay. Whenever you are in the cold temperature, like in Canada or Siberia, what happens? In order to conserve your heat, so that you do not lose your heat, you maintain your body temperature, what happens? There's intense vasoconstriction. Sometimes it may lead to Raynaud's phenomena. You will learn later. So intense vasoconstriction, inhibition of sweating, okay, and then ADH hormone, no urine formation at the time. So in that case, all these things are conservation of heat. And then whenever you are in a hot climate, in June, July in Saudi Arabia, what happens? Intense vasodilatation, sweating, so that you lose your heat. So all these things are regulated at the level of mainly hypothalamus, autonomic center. Now, generally, normal state heat production mechanism and heat losing mechanisms are in balance. So that is why you are warm-blooded animal. You are warm-blooded animal, you maintain your body temperature, core temperature, which is around 37 degrees Celsius. It is maintained. However, in situations when various pathogens arising from bacterial products, infections, various cytokines, IL-6 and others, what do? They act on the hypothalamus, and the heat regulating mechanism is reset. The thermostat set at slightly higher level, now you have fever. Heat regulating mechanisms are upset, now you have fear. This is a mechanism of fear because the hypothalamus is set. Now the new thermostat it is at slightly a higher level. So you feel fever. And antipyretic drugs, they act on the hypothalamus to restore the balance, to decrease that thermostat to a normal level, 37 degrees Celsius, so that now heat production mechanism will be reduced and heat losing mechanisms will be stimulated. We'll discuss in a detail later on, just a brief concept. So everything which has something to do with fever reducing, it will act on the hypothalamus. So biosynthesis of prostaglandins. Do you know this thing before? Yes. Okay. So membrane phospholipids under the influence of phospholipid A2, they are converted into another phospholipid, arachidonic acid. And arachidonic acid, there are two pathways. Nicotine synthesis pathway, which is known as under the influence of the first enzyme is lipoxygenase, and another enzyme is cyclooxygenase. Cyclooxygenase converts into prostaglandins and chromoxyl A2 and platelets, whereas alpha oxygenase converts into the final product is various liquid ions. Liquid ions. So in today's context, we are more concerned with COX pathway, cyclooxygenase pathway. So various prostaglandins like prostaglandin I, which is known as prostaglandin, prostacyclin, E2, F2 alpha, and thromboxane A2. Just keep in mind this COX enzyme. As I mentioned, the focus of today's lecture is COX. The things get more complicated, murky. Someone mentioned, who asked? You asked about the COX, celecoxib?
Yeah.
Can you recognize something from this slide?
That's only with COX-2.
So too far. So in order to understand the mechanism of action of the drug of your choice, which you mentioned, you have to understand the two isoforms of COX, COX-1 and COX-2. And this is, please, religiously memorize COX-1 and the functions of COX-1 and COX-2. Very, very important because they have a lot of implications on the clinical uses, on the side effect profile of COX-1 and COX-2. First of all, what are the differences? COX-1, it produces prostaglandins that mediate homeostatic functions, whereas COX-2 produces prostaglandins that mediate inflammation and fever. Can you explain this thing, this difference between COX-1 and COX-2? Yes.
Fever. COX-2 makes fever.
Okay.
COX-1.
Okay. So it is not the COX-1, it is the prostaglandin. So feel the difference between two enzymes, COX-1 and COX-2, because prostaglandins are continuously being produced in your body throughout the day, 24 hours a day. They have very fundamental physiological functions, like production of mucus in the stomach, maintenance of renal blood flow. These are fundamental functions of prostaglandins, which act on in paracrine fashion. What is paracrine fashion? When the cells produced by the cells act on the cells or the cells in the vicinity, surrounding the cell. They do not circulate in the body. They do not circulate in the body, but they act in the vicinity, in the paracrine fashion. So prostaglandins are being continuously synthesized by different cells in the body, different tissues, and they have very fundamental, important physiological functions. That is under the influence of COX-1. So COX-1 is continuously active. However, COX-2, the next is constitutive and inducible. Constitutive means always working physiologically. Inducible means whenever there is a need, and the need is when there is a tissue injury. Whenever there is a tissue injury, COX-2 will be induced, that will result in the synthesis of prostaglandins, which are responsible for pain, fever, and inflammation. Did you feel the difference? COX-1, COX-2, constitutive, inducible. Inflammation and fever and pain and physiological functions. Okay. Now, site. These are three fundamental differences between COX-1 and COX-2. The COX-1 is present mainly in the gastric mucosa. The function is production of mucus and a reduction of HCl production from the vital cells, oxynotic cells in the gastric mucosa. Kidney, maintenance of renal blood flow, vasodilatation. Platelets, rescue the endothelium. We'll discuss those functions. And here in the COX-2, it is everywhere. It is everywhere, but dormant, not working. Whenever there is injury, at the site of inflammation, it is induced and produces prostaglandins, which are responsible for development of all three features: pain, inflammation, and fever. Yes.
Only prostaglandin
E2, H2, I2, all, because they have different biological functions in different tissues. All are produced by the constitutive COX-1, but in different, because you see, different, for example, in GIT, it is mainly PG E2 and PG F2 alpha, which are responsible for production of mucus and reduces the secretion of. But in endothelium, it will be mainly prostacyclin, PGI2. So it is under the influence of COX-1, but it is a tissue specific.
But I think COX synthesize all of that COX.
Mainly PGE2 and PGH2. Okay. Okay. So once again, this figure will show you more detailed information. COX-1, constitutive, which is physiological activation, and COX-2, which is inducible as a result of inflammation or injury. And then it produces pro-inflammatory prostaglandins, and COX-1 produces prostaglandins for physiological functions. And you can see there are, on the later slide, we'll see there are non-selective NSAIDs, non-steroidal anti-inflammatory drugs. Non-selective means they inhibit both COX-1 as well as COX-2, non-selective, whereas we have selective COX-2 inhibitors, which selectively inhibit COX-2. In order to reduce pain and inflammation, what is required? COX-2 is required. So therapeutic effect comes from the inhibition of COX-2, whereas side effects come from the inhibition of COX-1. Okay? So that is why you will see results from inhibition of prostaglandin biopsies on the left side, unwanted effect because as a result of COX-1 inhibition, which has some very vital role in some physiological functions, that will be inhibited, that will result in unwanted effects like in GIT, kidney, and decrease in platelet aggregation because inhibition of PGI2. And on the right side, inhibition of COX-2 will result in very useful therapeutic effects like anti-inflammatory and analgesic. Is this concept clear? Yes, good. Now let's go to the drugs. All my lectures start with the background information and then the drugs. Now, classification of analgesics, non-selective NSAIDs, as I mentioned, they act on both COX-1 as well as COX-2. Selective NSAIDs, selective means COX-2 selective. And then analgesic, we have only one drug in this class, analgesic with poor anti-inflammatory activity. That's paracetamol. Okay, because we are calling. So non-selective NSAIDs, aspirin, prototype, ibuprofen. Do you know what is ibuprofen? All of you have used brufen. Brufen. Naproxen, very widely used. Indomethacin. And there are few, and keep in mind, in order not to confuse you, there are, I think, 30 or so non-selective NSAIDs, but I only used 4 names here, just which are very, very common and which are very, very famous. Non-selective are also at least 7-8 non-selective COX inhibitors, but I am focusing only on one prototype, which is also widely used, which is celecoxib. So non-selective, they inhibit both COX-1 as well as COX-2. Prostaglandin E2 and I2 increase nociceptor sensitivity to bradykinin, histamine, serotonin, and other pain mediators, as I mentioned in my earlier slides. Prostaglandin E2 sets the body temperature onto higher value in hypothalamus. So we will discuss with aspirin, and by default, all the things which we are going to discuss about aspirin will also mainly apply to other non-selective NSAIDs. Non-selective, not selective, non-selective. Okay. Aspirin is a prototype non-selective NSAID. So if we discuss aspirin, if there is some difference with aspirin and others, I will mention it. Otherwise, by default, this description applies to all non-selective NSAIDs. Okay. Aspirin is a prototype non-selective NSAID. Irreversibly, there's the difference. I highlighted it. Irreversibly, acetylates COX causing inhibition of prostaglandin synthesis, whereas others irreversible. I mean, reversibly, not irreversibly. So that means if COX is inhibited, bound by the aspirin, it is gone forever. The cell has to synthesize new molecules of COX. Otherwise, that cough is gone forever. That is why you will learn more in next year, CET class, why baby aspirin is preferred for platelets as an anti-platelet drug. Many of you might be knowing aspirin is used for the prophylaxis of myocardial infarction as an antiplatelet, a very small dose, 82 milligram. Do you know? Does anyone know? Raise your hand. No, does not. Because platelets do not have nucleus. They cannot synthesize new proteins. That is why when platelets are subjected, exposed to low dose of aspirin, that means they are inhibited for life. So very low dose is sufficient to cause maximal antiplatelet activity. Because there is a difference. Aspirin irreversibly acetylates the COX enzyme. Aspirin produces its major analgesic and anti-inflammatory effects by inhibition of prostaglandin E2 and prostacyclin biosynthesis. It's a site of inflammation. Applies to all actions. Antipyretic, of course. Anti-inflammatory, understandable. Analgesic, understandable. Does it need further explanation? It applies to all. Effect on platelets. Thromboxane A2 enhances platelet aggregation. Low doses of aspirin can irreversibly inhibit thromboxane A2 production in the platelets without markedly affecting thromboxane A2 production in other sites. That is why this is the drug of choice. Why? Can you explain why without affecting other cells, only platelets? Hmm? No. The question is, it does without in platelets without markedly affecting thromboxane A2 production in other sites. Very low dose. In order, the drug you are taking aspirin, 82 milligram, very low dose, extremely low dose, just sufficient to reach in the portal circulation. In other cases, in pharmacokinetics, I have told you, and others have also taught you, the drug must reach at the required site of action in sufficient concentration. Haven't we taught you? In this case, as an antiplatelet effect of aspirin, what is the target? Platelets. The platelets are target. So drug is not required to go to the distant sites. The target itself is coming towards the drug in the portal circulation. So extremely low quantity is required to produce an antiplatelet activity. Without affecting other cells means at other rest of the body, the drug does not achieve sufficient plasma concentration to produce other effects. So very low quantity, yes.
You also have to play with volume of distribution. Aspirin has a low volume of distribution.
No, it is not about it. It is because of extremely low concentration achieved in the systemic circulation, but sufficient concentration to inhibit platelets in the portal circulation. Because eventually, all the platelets which are circulating at some point of time will pass through portal circulation, will they? While passing through the portal circulation, they will be exposed to small doses of some molecules of aspirin, and it will be gone forever. And the aspirin is not going to other sites in sufficient concentration to produce some pharmacological activity. No, not at all. That is why we use extremely low dose of aspirin, because the target is platelet, irreversible acetylation, and the target itself is coming towards drugs. The drug is not required to go to the target. Clear? Okay. Other actions, GI effects, of course, you can anticipate because it is non-selective COX inhibitor, it will be having some effect on the physiology. GI effects physiologically, prostacyclin inhibits HCl secretion, whereas PGE2 and PGF2 alpha stimulate synthesis of mucus in the stomach. These both are protective, decreasing acid on the one side by prostacyclin and increasing the protective mucus by prostaglandin F2 alpha and prostaglandin E2, increasing mucus. This is also protection against the destructive or corrosive action of hydrochloric acid, prevention of peptic ulcer. Otherwise, do you remember the pH of the acid, I mean pH of the stomach, lumen? 2. It's highly acid. If you just touch that acid, that pH outside, in vitro, you will burn your fingers. You will burn your fingers, but your stomach is not burning, okay? Because of that protective mucus, the thick mucus protective layer that is under the influence of those prostaglandins. Whenever with those non-selective COX inhibitors like aspirin, that mucus production is inhibited, that means there is a high chances of developing peptic ulcer, especially the gastric ulcer. Because that protective layer, that is a mechanism of ulcer production in patients who are taking non-selective NSAIDs for extended periods of time. Clear?
For a longer time.
For a longer time. Kidney, as I mentioned, once again, constitutive role, physiological role of prostaglandin is to maintain blood flow to the kidneys. So kidney prostaglandin E2 and I2 maintain renal blood flow. Decreased synthesis of prostaglandins can result in the retention of sodium in water and may lead to edema after chronic. That is side effect. The GI is a side effect. Those side effects can be prevented by for giving either COX-2 inhibitor or I'll give you some other option. Indications, understandable. You can anticipate fever, pains associated with inflammation, antiplatelet, very low dose to prevent transient ischemic attacks and MI, myocardial infarction. Pharmacokinetics is very interesting. Low dose of aspirin is eliminated by first order kinetics and its half-life is 3 to 5 hours. What is first order kinetics? Who told you? First order kinetics of metabolism. First, we are not talking about first pass. First order. Constant fraction of the drug is being eliminated per unit of time. Okay. If the drug in the system is 100 milligram, 50 milligram, for example, 50 milligram, 50% of the drug is eliminated per hour. That means if the drug is 100 milligram, 50 milligram will be eliminated per hour. In the resulting 50 milligram, it will be 25 milligram, half, 50%. So this is first order. Sometimes the drug metabolizing and eliminating systems are saturable. You cannot go beyond a certain point. At that point, the first order kinetics of metabolism switches towards zero order kinetics. You increase the dose, the capacity of your metabolizing organ is saturated. You cannot go beyond a certain limit. It is saturated. You cannot go beyond a certain limit. Now, in that case, the constant fraction will not work. Then it's in that case, depending upon the saturation point, then it will be a constant amount of the drug will be eliminated per unit of time. So aspirin is a classical example, and ethanol, alcohol is another classical example of drugs which change the kinetics from first order to zero or slightly higher dose. The people who are addicted to alcohol, I've seen myself, they think that, okay, we are good with 2 pegs or 3 pegs. It's sufficient for us. By chance, I mean, the level of mental, I mean, it's good for 2 pegs or 3 pegs. By chance, they get the 4th peg. It turns the things around completely within few minutes because the saturating enzymes are completely saturated, metabolizing. Now, slight increase in the concentration of the drug. Now, the drug follows zero order kinetics and the plasma concentration becomes very high. When the plasma concentration will fall to a certain, it will once again become zero first order. Because the trigger point here is that your metabolizing enzymes are saturable. It is not the case for all the drugs, but some classical drugs like aspirin, like ethanol, like phenytoin, you will learn in neuroscience block, anti-epileptic drugs. Initially, they follow first order kinetics. you go on increasing the dose. At certain point, completely saturated, they follow a flat curve. Okay. First of all, zero order kinetics. At that point, there is a toxicity, high toxicity, because the drug is not being eliminated properly. Yes.
But for us, inflammatory effects, for anti-inflammatory, would be the very high dose last.
Initially, yes,
So won't it be versus zero order?
it will be if you continuously use high dose for extended period of time, you will achieve a certain point where it will convert into zero order kinetics, and that is the point where you will, in the next slide I have covered, where you will experience toxicity of the drug. Okay. Now, understand this bullet. Low dose of aspirin is eliminated by first order kinetics, and its half-life is 3 to 5 years. While high dose is eliminated by zero order kinetics, and its half-life may increase up to 15 hours. Half-life will increase now. You will feel now toxicity. Can you explain why? We explain. Okay. Okay. Aspirin adverse effects, of course, understandable. Salicylism, high dose of aspirin causes tinnitus. Why do we call it salicylism? It was used called acetyl salicylic acid initially. It was salicylated. So based on that salicylism, the term was coined as salicylism. High dose of aspirin causes tinnitus, deafness, nausea, vomiting, and occasionally abdominal pain and flushing. Dyspepsia, GI bleeding. Do I explain? Do I need to explain? I explained already. Because of decreased mucus production and increased acid production. Prolonged bleeding time. Why? What is bleeding time? So it's the time to when the small vessels actually stop bleeding. When you measure it, it is a function of platelet aggregation, not the platelet count. It is a function of the platelet count as well, I think. Yes, platelet count. Platelet count as well as platelet function. So under the influence of aspirin, the platelet will be inhibited because thromboxane A2, which is the main platelet aggregator, will be inhibited. Platelet function will be lost, and the bleeding time will increase. Wheezing, sometimes accompanied by urticaria and rhinorrhea in aspirin-sensitive asthmatics. An individual who is aspirin-sensitive is predictably sensitive to other NSAIDs that share its pharmacological effect on cough. Why? Why asthma and those allergic symptoms? Why? Is there cough in the bronchial smooth muscle? Yes. Oh, exactly. Bravo. Now, this is the thing, because you see, conceptually, arachidonic acid is synthesized, is converted into through COX pathway into prostaglandins. When that COX pathway is blocked, arachidonic acid upstream is still there. Somehow, physiologically, when you block one pathway, compensatory mechanism, the alternative pathway is activated. In the case of arachidonic acid metabolism, it will be the lipoxygenase pathway, which will be activated compensatory, because arachidonic acid accumulation occurs. Okay. So as a result of lipoxygenase pathway activation, what are the products, as you mentioned already? Leukotrienes, which are powerful bronchoconstrictor. And you will learn in the coming year in the management of asthma, leukotriene receptor antagonists are very, very important to manage patients with asthma, like Montelukast. Leukotriene receptor antagonists or leukotriene production inhibitors like prostaglandins and receptor antagonists are important mainstay in the management of asthma, because leukotrienes are bronchoconstrictor. Okay. Now, this is unexplained thing, Reese syndrome. a rare condition in children with high mortality, is characterized by hepatic failure and encephalopathy. This is only with aspirin. Occurring in the setting of a viral infection illness, it occurs after ingestion of aspirin. The cause of this epidemiological association is unknown, but this happens, and it is potentially fatal, Reye syndrome. That is why I will share with you in the next slide. Aspirin is contraindicated in children with viral infection. Never give aspirin to children. Have you seen aspirin syrup? Just like you see paracetamol syrup, brufen syrups for use in children. Have you ever seen aspirin? They are never prepared for children. Okay, aspirin adverse effects, once again, they are understandable. Suppose a patient requires long-term treatment with an NSAID, what would you do to minimize the risk of development of peptic ulcer in the patient? One option is selective, but if someone is having a good response with non-selective and not getting good response with it, because patient-to-patient variation always occurs. In that case, you have another choice. You can use non-selective NSAID along with another drug, which is known as misoprostol. Misoprostol. Misoprostol is a synthetic prostaglandin E2 analog. It will prevent the development of peptic ulcer while not affecting the anti-inflammatory analgesic effect of aspirin.
Won't this have other adverse effects in the body?
Because it is only in the stomach, misoprostol. Because it is mainly prostaglandin E2 analog, and what is the main mediator of inflammation? So it will having a protective effect. There are some combination drugs available in the market where non-selective NSAID inhibitor comes together with misoprostol. And we will discuss about misoprostol in my upcoming lecture on antihistamines and drugs acting on arterites in more detail. Just this was a passing remark. Contraindications, once again, based on the pharmacological actions, you can figure out on your own. Tell me 1, 2, 3. Pregnancy, children, yes. Bleeding disorders, yes. Ulcers, asthma. Asthma is not absolute contraindication because it doesn't happen to everyone. Okay, renal failure, very good. Peptic ulcer, most common. Esophageal varices which are bleeding, in cirrhosis of liver. Bronchial asthma, that is, once I mentioned, it is not absolute contraindication. It is a relative contraindication. Relative means because if someone has a history, you can give a dose of 1 or 2 and then see if the patient is developing, then avoid it. If not, because it happens rarely, not in all patients. Viral infection in children, bleeding tendency. Now we will switch to selective COX-2 inhibitors. Only one drug I mentioned, there are several others. Celecoxib has advantage of less adverse effects related to COX-1 inhibition. Of course, it is understandable. And then paracetamol. All other anti-inflammatory effects of celecoxib are very similar to non-selective, except the difference being it has minimum side effects compared to the non-selective. Now, if I ask you the therapeutic effect of non-selective NSAIDs comes from COX-1 inhibition or COX-2 inhibition? Or both? Both? Therapeutic effect. COX-3. What is COX-3? Huh? There is the COX-3. It is not actually COX-3. It has been named COX-3, but I think actually it is a splice variant of COX-1. Okay, splice variant. Some researchers name it COX-3, some is a variant of COX-1. It is only present in the brain and the heart. And I explained it to some extent in the context of paracetamol, but we are not sure. Keep in mind, paracetamol, the most widely analgesic and antipyretic. Panadol is antipyretic and analgesic with little, if any, anti-inflammatory properties. Whenever we don't know much about anything in detail, that means there are a lot of hypotheses, postulates coming, confusing things. So paracetamol, although this is very interesting, we are using paracetamol so widely, it is over-the-counter drug. Over-the-counter means the safety of the drug is so established that you can use on your own, you can buy from the supermarket, from Hyperpanda, from Tamil, it's always in the counter, Panadol. The safety is so widely established that you can use anytime, anywhere, by anybody. But still we don't know the actual mechanism. How does it take? We only know that it is very good analgesic, very good antipyretic. It is minimal anti-inflammatory activity or none. But how does it act? When we don't know in detail, that means this can be possible, this can be possible, this can be possible, everything can be possible. So the strongest things which come in favor of paracetamol's mechanism of action, I'm mentioning to you as a food of thought, food for thought. It has no return effect on the gastric mucosa, like NSAIDs. It is useful in pediatric since, unlike aspirin, it has not been associated with Reyes syndrome. Very safe. Despite wide use and excellent safety profile, the exact mechanism of action of paracetamol is still elusive. There are various theories, and all seems logical. They are logical. Paracetamol inhibits prostaglandin biosynthesis in the CNS by acting at a splice variant of COX, which is COX-3. And since it only acts on the CNS, that means it is mainly antipyretic. But then the analgesic activity of this paracetamol cannot be explained on the action on CNS. Can you? Analgesic activity cannot be explained. You can explain antipyretic activity on the basis of COX-3 or splice variant in the hypothalamus, but you cannot explain analgesic activity of paracetamol. Very good analgesic it is. Another theory, it is weak anti-inflammatory because it works peripherally, like other COX inhibitors do. But the effect is weak anti-inflammatory because it has poor ability to inhibit COX in the presence of high concentration of peroxidase, which are found in the sites of inflammation. So whenever there is inflammation, this drug does not work. But it continues to work as analgesic and antipyretic. So it is good for pains not associated with inflammation. It's like headaches, body aches, it's good. So whenever there is inflammation, there are peroxidase and it does not work in that situation. That also explains the analgesic effect of paracetamol. So poor anti-inflammatory, but good analgesic. So it works like other NSAIDs, but it does not work whenever there is inflammation. Is that clear? So this is another explanation. Indications: widely used antipyretic, good analgesics for acute mild to moderate nociceptive pain. First line therapy for low back pain and osteoarthritis. Toxicity of paracetamol is important to understand because although it is very safe, some people have the tendency to engulf so many tablets at a time, or it can be accidental by children. I mean, because of the syrup, Panadol syrup, it's sweet. It may be tasty for some children. Without your knowledge, they take out the fridge and they take out a whole bottle syrup and sweet. So because of its wide availability, easy availability, it's in home, in every home, it's bound to produce toxicity in some people. You need to understand. It is metabolized in the liver. The major metabolites are sulfates and glucuronides, which are excreted in the urine, physiologically. However, when paracetamol is taken in overdose, the capacity of these conjugating mechanisms is increased and a reactive metabolite in acetyl benzoquinone, NABQN, which is on NABQI, is formed by a cytochrome P450 dependent metabolic process. Because you are now metabolizing a lot of drugs, this intermediate metabolite is synthesized. In general amounts, I mean, moderate amounts, the liver has the capacity, hepatocytes have the capacity. Generally, it is toxic, very toxic, okay, and causes hepatocellular damage unless inactivated by conjugation with reduced glutathione, which is what is glutathione? It is antioxidant. Yes. Hmm? Which is neutralizes? Glutathione. Glutathione.
Yes.
Yes. So generally it happens whenever there is a low to moderate dose, glutathione works wonders to inactivate, to decrease the toxicity of that metabolite. But beyond a certain point, the reserves of glutathione are still saturable. The stores of glutathione are still saturable. It cannot cope with the increased amount of that metabolite. In that case, when there is a very high dose, that metabolite NABQI will actually cause toxicity. In that case, there is one antidote, which is acetylcysteine. It's a specific antidote of paracetamol toxicity. Acetylcysteine is given to reverse paracetamol-induced hepatotoxicity as this repletes the supply of reduced glutathione in the liver. Just like replenish the amount of glutathione in order to detoxify the metabolite. Clear? Any question? I think we are done now. Yes. Considered that? Yes, it is. It is. Name. Physical fair names. Oh, this is name. In acetylcysteine. Yes, same. Yes, listen, in the books, because we are under the influence of American literature and culture and textbooks. All the books you will read will be mainly Rippenkar or Kedson or whatever. They'll be American books. You will find in the American books the name as acetaminophen, not paracetamol. Acetaminophen is an American name for paracetamol. It's a mainly political thing. But we in Saudi Arabia, we follow the British terminology, British pharmacopoeia, BP. There are two pharmacopoeias. Pharmacopoeia means naming the drug, nomenclature of the drug. So according to USP, United States Pharmacopoeia, the name of the same molecule is acetaminophen, but in British Pharmacopoeia, the name is paracetamol. We follow in Saudi Arabia paracetamol. If you look at Panadol, the active ingredient written is paracetamol, not acetaminophen. But in the books, you will find, don't confuse, it is basically the same, acetaminophen and paracetamol. Yes. Can you open the attendance, please?
We need to know the mechanism of action of
Not necessary. Not necessary. But of course, you need to know.